This next session is a bit of a romp through really serious projects, really serious thinking that's going on around acting locally, delivering locally, because that's a really important part of today's, it's actually what's going on. So here are 5 presentations, 1, 2, 3, I think 5 presentations that will all kind of complement each other, but also serve to show some distinctions between the whole notion of palliative training and education, how you work with local communities, how you work with other groups, not necessarily people with life-limiting illness, but other groups, other vulnerable groups within the community. Because palliative care reaches all vulnerable groups, not necessarily about particularly serious life-limiting illness. So without further ado, I'd like to introduce Professor Fiona Wilderson, one of our trustees. And then can I suggest that we just go straight on one from the other, gathering questions and comments as we go through the chat. And then we'll have a chance to have a panel discussion at the end. The conference is being recorded, so there will be an opportunity to go back over some of the detail that you might have missed. So thank you very much.
Thank you very much, George, and welcome everybody. Croeso, if you know Welsh, and welcome to everybody from around the world joining us today. And I don't know what number Palliative Care Works conference this is for me, but every year already there's something new to think about, and the absolute priority for correct, factual palliative care messages and education to get around the world is an imperative, and for us all to be supporting each other and networking and collaborating is an imperative. The world is a very tense, fractured place at the moment, and I think palliative care is in danger of being sidelined because of other huge pressures. So I think it's up to us as a community to really keep that flame going. I wasn't going to spend very long at this conference today talking because so many other people have got so many really important messages to share, but I wanted just to take over a couple of minutes to refresh people's memory for our impact survey that we did last year, and just to pose some questions that as we are developing our programs and our network and our collaborations, we embed implementing evaluation into those programs. Because if we think that palliative care has got the risk of being disenfranchised, I think palliative care education is also under threat, which makes our role so much more important, both with the education and with the support, with the mentoring and training. So very briefly, just a reminder of what do we measure? When we gather people together to talk about palliative care, whether it's formal training education, whether it's a raising awareness session, what do we measure? We can measure enjoyment. That's always nice to know. But if you've put the time in, if people have given you time to attend or to join online, but they've enjoyed the experience, that's good. Do we know what happens to personal learning? Will it make a difference to that person? And sometimes we don't know what difference that's going to make. And actually, I think sometimes some of the most exciting impacts of education are the things that you don't quite expect. So already I'm leaving today, when I leave, learning and thinking about something new, thanks to the presentations we've already had this morning. But is it going to make a difference to personal practice of palliative care? Will it change how we practice, how we communicate, how we speak? And then, of course, will it make a difference to patients? And those questions are the ones that are outlined in the Patrick's model of evaluation. And these, if you look at the literature for evaluating education in palliative care, there's a lot around level 1. There's a lot around that experience, that reaction. There's a little bit about learning, but there's not huge amounts at these higher levels. What difference will it make? But of course, if we want to engage with our funders, or if we want to engage with people to help us deliver palliative care, we do need to be able to think and collect that, because it may be that sort of language that's going to change people's minds about whether they want to invest in their, hopefully funds, but definitely time and energy. So just a brief reminder and thank you to anybody in the room and thank you to anybody online who contributed to our survey last year, and the reminder, just the catching up survey that we have rolled out over the last 6 weeks. We have been really keen to evaluate where palliative care works has contributed, how it's contributed over the 15 or so years that training programs have been in development and have been delivered, and as we reported at conference last year, and the report is there and it will be updated by the end of the month, we know that there's been a lot of impact around face-to-face training, around the online version, particularly using the palliative care toolkit as the focus. And how important it is not to reinvent the wheel. We've got something that we know works. So it works, it still works. It's fit for purpose. So let us continue to use that as our basis for training. We've got training film sheets and there's lots of stuff on the website. But the needs remain. So we got some very, very useful information. As I say, thank you. And that's what's driving our vision really moving forward, and with our new branching out with our associates. There's a lot of work to be done, which is really, really exciting. And it's exciting to try to make it fit for purpose with the ever evolving technology and ways that we can teach. But there is still a lot of work to be done. And we've heard from Robert as the meeting started this morning, how important it is that we learn the language of advocacy. So as well as teaching, we are empowering ourselves as this wonderful global palliative care network of people who are striving to make a difference for people with life-limiting illness. So we need more morphine. We need more morphine availability. We need advocacy. We need to know the language. We need to feel empowered in how we deliver palliative care across the world, to know the language when we are interacting with health ministers and governmental ministers, for whom that language of death and dying might not be what they want to hear. So how do we get through these barriers? As part of our communication skills, teaching and training can actually involve that as well. And of course, we need to remember the language about how we're talking with our healthcare professional colleagues and with our communities, our informal carers, patients. How can we empower our patients in really difficult situations to do the most for themselves they can with what little that they've got? So it's a big, wonderful kind of collection, a very vibrant collection of things that we're teaching. And of course, our networks and collaborations, these are what's important. And so I think I had one last slide. This was just the slide from last year, the impact of our training and where perhaps in the future we're going. But this is the real discussion that I'd love to start from here today. There are lots of different ways that we can evaluate our work. There are lots of different ways that across the world, people involved in palliative care can evaluate the work. I think bringing our thoughts together at the conference today, following today with associates, it's about what questions can we ask, and in fact, can we develop a tool that we can all use, a little bit like the toolkit? Can we develop a tool that runs alongside the toolkit for how can we evaluate not only enjoyment, although that of course is really important for the people delivering the palliative care, but actually that impact. So the higher levels of Kirkpatrick, what does it do to change people's practice? So I'm leading on this part of Palliative Care Works, and I would be really, really keen to hear people's ideas moving forward. I think there's something about a few months after an education session or a link or a mentoring session, actually what have people been able to put into practice? And if they haven't been able to put anything into practice, why is that? Ministries change, people change. If you find somebody who opens doors for you, then we have to use that, but they don't stay forever. So keeping us up to speed how that kind of environment works will be very helpful. that's really all I wanted to say today, but hopefully just to kind of to push some ideas out there, and we are really, really keen to continue this discussion. But I'd like now to make way for people who are going to describe some of the wonderful things that they're doing around the world. Thank you very much for your attention. Thank you.
And it's my pleasure to introduce Ruth Alderton, who's our latest trustee joining the PCW board. He's going to talk about a different aspect of palliative.
Yes. Morning. Hi. Afternoon, everyone. Yes, I'm Ruth Alderton. I'm a trustee with Palliative Care, but I'm an advanced nurse practitioner at Prospect Hospice in Wiltshire, which is just about an hour west from here, for those of you that don't know. I'm just going to basically introduce Anu, who's going to do a presentation about addressing inequalities in palliative care access through her experience in India. And I know Anu is known to many of us here, particularly with Michael and various other colleagues. So I'll hand over to Anu, and I think she's going to be presenting her own slide or sharing her own slides.
Thank you for this great opportunity. So my presentation is increasing access to address inequity. I'm a nurse consultant. I'm coming from India, and unfortunately, 98% of stage 4 cancer patients in India do not receive palliative care, and less than 1% receive opioid-based pain relief as per 2024 results. Significant and growing disparities in health persist, often due to barriers established at various levels of the society. We do have a lot of inequality issues there. Today I will be presenting about two communities. One is a resettlement area and the other one is a transgender community, in both of which I am working for the past few years. In both communities, there is absolute no access to palliative care, and there are socioeconomic issues like poverty, unemployment, low education, inadequate housing, lack of citizen ID, exposure to violence, lack of healthcare services, and inaccess to public health services. So first is a slum rehabilitation settlement area. So this area is in Chennai, India, where 1 lakh slum dwellers were with poor access to basic facilities. Multiple human rights violations are there. Caste conflicts are there. Violence against women, alcoholism, drug abuse, etc. without an appropriate social support system. And what happened is we were running a small NGO with only home care facilities, that too on a two-wheeler. What happened during the COVID, when every other palliative care services was stopped, we received call to support a few patients in this slum resettlement area. So we started taking care of, first started with 10 and then escalated, increased to 20. We had so many challenges while providing care, designing a service in the COVID, considering contextual forces, structural characteristics, and limited resources. What we could do was we started nursing home care with support from the inhabitants to enter the household. And then we planned for doctors' home care, physiotherapy assisted devices, medications, and food kit. We also started some volunteers training, facilitated employment opportunities and educational support. We knew that we could not do more because of the structural issues, but with what we could do, we continue to do. And the good part is government has understood the work that we do, and government has taken initiative to support us by building a 10-bedded hospice palliative care unit with a training center, with hostel facilities, with kitchen. And this is something like first in kind of India, completely built by the government and handed over to an NGO. Now we have regular home care, we have home care vehicle, patients are there. Last week we had 8 patients out of 10, 8 out of 10 beds were filled. And this is a success story that I want to share. And the inauguration was last year. And after 1 year, we had 100 new patients. Next is the Hijra community in India. Hijra is an umbrella term used for those people who are transgender, eunuch, bisexual, transsexual, transvestite, intersex, and bigendered, and etc. etc. It is little different from the Western world. Kotis are effeminate males who prefer feminine roles in the same-sex relationship, and Pandis are their masculine characteristics. They live together. Transgender individuals in ancient Indian epics held esteemed roles, but due to discriminatory laws, they now live marginalized, like lives in modern India. This is the community where I am closely associated with. The living status from the diagram, it is clear that most of them, 35% of them, we don't have exact data of everybody, but with the data, this is what we have in India. 35% of them live in Gharanas, living with the guru and in the which is called Jamaat leaders. Then others peers as with husband, parents and family, but this 35% is the marginalized community. So the Jamaat, the continuity of a cohabitation system for transgender people, formed an important support system. It is called Jamaat, and the social ties are formed with Reeth. And the to become the castration is called Nirvana, to make you to understand a little bit of about their background and their home. The community is called particular Gharanas. The head of the household is called Nayak or Guru, and under the Nayak, they are disciples or chelas. The core survival is Badai, rituals of clapping their hands and asking for alms, giving blessings on happy occasions through songs and dancing. But 80% of them are sex work and begging. And this is again the community that I am working with. So they are mostly excluded from their families because we have kind of male dominance and preference for males. And the moment a male is becoming a female, it's very much unaccepted in the cultural system. So pervasive stigma and violence due to multiple marginalized social identities, including sex work, physical abuse and harassment, gender non-conformity, etc., excluded from participating social and cultural life, economy and politics and decision-making process. Social inequities exist, like they don't have even high school education. Like they have issues with because they don't have the voting card or the citizenship. They have problem with even continuing their studies. Economic housing inside there are housing insecurity, employment discrimination, and all the more ending up with poverty. They have healthcare needs. As I mentioned, most of them are HIV/AIDS, the sexual workers. So HIV/AIDS prevalence is highest among them in India. High comorbidity and premature mortality, lower chance of receiving regular primary care and screening, poor health-seeking behaviors, high risk for drug abuse, alcohol, suicide, depression, violence, and aging. Effects of castration. Not everybody have underwent the surgery sex reassignment surgery, but there some of them like are living with the tradition, who have underwent the traditional method. Poor living, hormone, substance abuse, sex work, and trauma, and ending up in suicide. And I am working with a Nayak, and this is when I heard about the suicide part. I thought I will be able to support the community, but I couldn't. That's where we started working together. So in our hospital, we started inclusive palliative care services. This started in 2017. We had that time we had a doctor trained in transgender personnel and trained in transgender health from administration, and this was the first and the only one which is transgender, which we were about to accept transgender people in our state. But until then, not even one single person have come for palliative care. So we started searching barriers. So we conducted workshops, days of workshop, seminar, interviews with them, and different methodologies. Cooperative participatory initiatives, workshops, interviews, multiple discussions have taken place, and we understood that hospital-based care models may not be able to ensure equitable palliative care services to this community. They had challenges: personal challenge, community, society, and institution. Institution comes on the last. They had all the other challenges, so they could not even come to the institution even if there was a need. So we learned that we had taken research studies on lived experience of elderly transgender people, currently taking lived experience of patients who are HIV positive among them. So experience complex service needs and multiple barriers in accessing existing services. Without a true understanding of these patients' lived experience, it can be difficult for professionals to improve their access to palliative care. Each Gharanas will have to be studied and understood as a separate entity, as rules are specific to each depending on the current Nayak. So the one Gharana, the implementation of the understanding of one Gharana will not help to help establish services or help the other Gharanas. Ensure respect, safety, choice, and control. So we have gone beyond palliative care like outreach activity, stigma and discrimination reduction efforts, self-help support groups, social services, community development, vocational training, literacy, employment, mobilization of resources. During COVID, we had hand sanitization projects so that they will produce and they can generate some income. What we did doing and what we have to do is like we had drafted a curriculum for nursing students to know more about the transgender health care and the how to care them during the transition. Respectful healthcare advocacy initiatives have started and doing early screening programs for them has taken, initiated research project, trained palliative care MDT with specialties for gender affirming care, currently doing legal and social support for them, integration into it. So what we were trying to do was there is existing AIDS, state AIDS control board who are undertaking screening, the monitoring of these patients. So we thought of collaborating with them, training them in palliative care so that we can have even early integration of palliative care whenever they need, and then slowly extend it to other healthcare issues and treatment issues and treatment initiatives. To do model for targeted community-based palliative care, embedded clinics, nurse-led palliative care activities, palliative care modules for transgender communities in a general thing. This was what we planned. Unfortunately, this year, June, the existing service, the state government was supporting the transgender, this particular NGO with funds, with this NGO was taking lead for HIV prevention initiatives. They stopped support. Initially, we thought we will get it back the support that they were receiving, but unfortunately no. And now we have to start all from square one. Even the existing support was lost. So it was like a snake and ladder maze. We got ladders. We were going up. We were going up, thinking that we will be able to do it very soon. The integration with the AIDS control board, but the entire project was followed. And for months, for June and July, we were not even out. We were like inside a kind of snake. Don't know what to do. But now we understood that we are back. We are back to square one. So what you spend years building may be destroyed overnight, build it anyway. So when we work for a community, marginalized community, we have to work with the community. So a few pictures, this is my pregnancy, and this person standing behind me is a Koti, effeminate person. So when he was included for it's a religious kind of cultural practices, he was so happy. And the next is my son, and taking care by the community members, giving bath, and their baptism where they a small function where the transgender community and the daughter is an adopted daughter. They got it from street. They really do really good work in the personal life. What I learned, these are my kids now. It took years. Suffering is not easily measured. Resistance and failure will happen. Things will take time. Change is slow. I have a role to make it happen, and you don't need to wait. We don't have to wait. Nothing will change if you don't try. Keep showing up. You have to be persistent. And this actually was a very difficult to take it up. And my friend told that we are working together. We still understand the need of this, and we know that what we are doing is something good, and something will benefit. May not be now, but it is okay. So working together is success. And if we see outcome, that is the bonus. So I really liked it. So but we couldn't achieve anything, but we see working together itself as a success now. Do not wait for leaders, do it alone. I like Mother Teresa's quotes. Do it alone, person to person. Thank you. And it's the last slide. Never worry about numbers. Help one person at a time and always start with the person next to you. Your legacy is the life that you have ever touched. Thank you. Thank you very much. Thank you, Seema ma'am. Seema ma'am has helped us so much.
Yeah, that was so powerful.
We couldn't get anybody to understand their psychiatric need and then what can be planned for, what to be planned in, for palliative care, and madam has helped us.
So I think you can see what is behind me. There is always hope.
Thank you, ma'am. Thank you.
Thank you, Annie. That's an amazing presentation. Thank you. And I first heard you talk about your work as part of a conference that the Global Palliative Nursing Network could arrange. So Marie might can be talking about that a bit later on. So just shows how all these networks are coming together and people are being empowered, which is amazing. So yeah, I think it's Sally next, talking about her work in Kenya.
Thank you very much.
Right, hello everyone. I'm Sally Hull and I'm the chair of trustees of Hospice Care Kenya. And Hospice Care Kenya began way back in 1991 as the Nairobi Hospice Charitable Trust. And Ruth Aldridge, who's sitting in my chair, who invited me to speak today, she was one of the original founders of this organization. And the number of organizations supporting primary palliative care in Kenya has grown enormously since that first seed was planted. And actually, in last year, there were 106 palliative care providers on the website of KEPCA, which is the Kenya Hospital Palliative Care Association website, which is amazing. So we in Hospice Care Kenya, we raise funds in the UK to provide financial support to hospices for project work, for drugs, and for training. And initially when we started, the training was really for nurses and doctors. But since 2010, we've really changed and put a lot of effort into supporting hospices to train community health volunteers, workers. They're now called community health promoters. And why? Why did we change? Well, as I'm sure all of you know, community health promoters are volunteers which are chosen by the community. They're usually chosen at community meetings or barazas led by local chiefs. And they're known and trusted, and they are well established within their local communities. They're also very sustainable. They may stay a long time in their own communities. And indeed, amongst the ones we train, 12 years is the average time that they spend within their local community.
Wow.
And they're also part of the existing healthcare structure in Kenya. And as CHPs, they get some standard training from the government, or should do. Basic training covers the health system and their role, and then technical training includes hygiene, maternity and child health, family planning, HIV, but not, of course, palliative care. So on the whole, it's the independent hospices and increasingly the palliative care centres within government hospitals which provide the training for palliative care. And each CHP looks after approximately 100 families in the neighbourhood. And they're supervised by community health assistants who are funded by the government. Another reason, of course, to support CHPs is they are low cost, but actually they're incredibly effective. And the other thing that I'm sure you all know about is that the amazing mobile phone coverage in Kenya, somewhere like Kenya, and I'm sure in other places as well, what that means is that a lot of the support to the CHPs can be given over the phone by nurses, or even occasionally by doctors. I'm a doctor by training, But also some of the training can be given over the phone, which is really impressive. There's great enthusiasm for additional palliative care training. This was a group of people who had some training in Kisumu the time before last when I was there. And of course, you'll see that most of them are women, and they spend about 8 days a month on their role as CHP, but they all run additional businesses or have additional jobs as well. And they're now called CHPs, as I said. Previously, they were volunteers. And they're meant to be paid a small stipend, but community health policy is devolved to the 42 counties within Kenya, and they have somewhat varying approaches to supporting and paying their CHPs. And so those two quotes, I think what they illustrate is both the financial problems of the lack of payment, but also some of the enormous non-financial benefits of being a CHP and why a lot of people want to take on this role within the community. I'd like to introduce you now to Stella. Stella Rithara is a nurse who teaches at the Kenya Medical Training College, and she also runs her own charity amongst the Maasai population. Now, I'm just hoping I can make this video play, and she answered some questions. Can you make this play at the bottom? There's a little thing that plays the, there it is, down there at the bottom.
So just get the mouse there.
I am Stella Rithara, a palliative care nurse, currently working at Kenya Medical Training College as a palliative care tutor. I'm the founder and director of Ongatagong Palliative Care in Kajiado County, where my role is creating awareness on palliative care, training community health promoters, assisting them, and also visiting patients at home, working hand in hand with the county hospital, whereby we refer patients and refer to us. To become a community health promoter, you must have interest in working or serving your community. You must be living in the same region or location, have some knowledge of the geographical area, able to read and write, which is very important during the training and also writing reports. After being selected to become a community health promoter, the government has a training module whereby you are trained on how to handle the patient, common illness in the region, basic nursing care, how to support the patient when they are in need. CHPs need extra training, especially on palliative care services. This is because the government module mostly is on communicable illnesses. Again, palliative care patients stay for long at home, and the CHP need to understand the care needed for that patient who is not going to get well very soon, and also need continuous support socially, spiritually, psychologically. So it's so important for the CHP to be trained more on palliative care services. And this is where we say thank you to Hospice Care Kenya to have come to assist in training and giving more knowledge on palliative care services to CHPs. CHP are very key persons in cancer care. They support the patient at home, especially after discharge from the hospital. They support them during clinics. They report or refer in case of distressing symptoms at home to healthcare providers or healthcare facilities. They're the ones who link between the community and health services. CHPs are not paid, but they are given something small by the government to facilitate movement from patient A to Z, and also to be able to call the health facility or health provider in need when the patient in need. Community health promoters are motivated by assisting the patient. By the name, they are called community doctors, and they have the passion to do it. When they see a patient, when they visit a patient at home, and the patient get well, and the patient have a smile on the face, this motivates them, and they keep on by supporting each other. Working in the community, we encounter some challenges, especially distance from one patient homestead to the other, from CHP's home to the training facility. This brings the timekeeping challenge that some CHPs will come late and others might want to leave early. And we understand because they need to tend to their animals, walk long distance to fetch water. Others, they become overwhelmed with the palliative care patient needs because they are used of communicable diseases where patients are treated and they are well. We understand that and we give them time. If they want to step aside, that's okay. Then they can join again. Then this becomes a challenge because one area falls without a CHP.
Right. Yeah, so Stella has touched there on some of the difficulties of working with palliative care patients in the community, patients who won't or can't access treatment, patients who get sicker or may die. This can cause real difficulties, I think, feelings of guilt or blame, and CHPs can disengage. And this all needs to be addressed in the palliative care training modules. And this is Stella. This is Stella here, teaching during a session with the Maasai. And in the little one, you can, if those who have got sharp eyes will be able to see me sitting beside Stella and taking it all in. So we've invested very heavily in CHP training over the last 10 years or so. At an average cost per CHP trained of approximately £42, but you know, the projects vary enormously in quality and the time spent on training. But you can see over the years, that's our investment. Now, I want to talk to you a little bit now about the DFID project that we ran. In 2020, we were awarded a DFID project grant of £50,000 to support CHP training in 3 different areas within Kenya. This was complicated by got tangled up in the COVID crisis. But in spite of this, amazingly, the partners in these hospices managed to run the training, collect the data, and complete the project on time, which is quite remarkable, actually. Now, as this project was actually developed by HCK, we were able to ask a little bit more of our partners. It allowed us to ask for some data and data collection on the impact of training on CHP technical knowledge, for example. And so what we did was to use a 20-item multiple choice quiz, pre and post training. And on average, there was a 30% improvement. And yeah, people enjoyed it and they felt more able to respond to patients' needs. The project also included the African Palliative Care Outcome Scale, APCA-POS, to try and examine the impact on both patients and their carers. And what we wanted to do was to demonstrate, particularly to the hospices themselves, the benefits of using a tool like this. Yeah. So both patients and carers were meant to complete the APCA-POS assessment pre and post intervention, and we only got about 12% of people to do it pre and post, which is a small sample really. And of those, 57% had a diagnosis of cancer. Now this just shows the results. The blue lines are the pre, which are higher than the post, which are the orange. So as you improve, your score falls. And so what you can see is that there was, amongst this relatively small sample, a real benefit to particularly things like worrying, pain, and feeling at peace, both amongst the patients and amongst their carers, which was a really important change. And I think what was really encouraging was that the teams themselves began to see the value of using a tool like this and to see where they might be able to improve care for patients. So the legacy of this project included not only the training for the 200 or so CHPs, but also engagement with a whole lot of community leaders, which is really important, politically speaking, but also a demonstration to these teams of the benefits of improving training, both to the CHPs themselves and to the patients they care for. And the feedback from the project suggested a few areas where CHPs need additional support, particularly in bad news. That's a really difficult area. Managing pain relief. We need help with that, and how to engage with people earlier on in their illness trajectory. So I think final comments about this is that the success of this project, and it really was a success during the COVID epidemic, was built upon a long-standing relationship with these three hospices, but also with gaining support from KEPCA, the sort of umbrella organisation for all the hospices in Kenya. And it helped us to identify new training needs and to push hard for some of the improvements, such as routine use of the APCA-POS. I think, just to finish, I think the history of the story of Nairobi Hospice illustrates the amazing development of the hospice sector in Kenya over 30 years. So there we are, 1991, and we had the great pleasure of visiting their newly built hospice last year. Amazing, and we're really pleased to be part of that journey with them.
Wonderful.
Hello, Seema, you're very welcome. It's George here.
Hello, am I audible?
Yes, yeah. That's like that we can hear you loud and clear and see you too.
Yeah, great. Thank you. Shall I share my screen and start?
Please do.
I hope it is visible now.
Yes.
Yeah. So thank you so much for inviting me to discuss this often overlooked topic, in palliative care, about the mental health issues that we face when dealing with patients with terminal illnesses. Before I start, I would like to give you a brief glimpse of the place that I work. This is a 73-bed inpatient hospice for terminally ill cancer patients in Bengaluru, that is in the southern part of India. We also run a 110-bed hospice in Bhubaneswar, Orissa, which is in the eastern part of India. And these services are, we are a public charitable trust, and we provide services to cancer patients entirely free of cost. We don't charge them anything. And this is KIPSR, the Training, Education and Research Wing, which looks after the research activities in these two institutes and also looks at quality improvement. So this is the brief background of where I work. So coming to the topic today, I will just talk about what the importance of mental health in palliative care and our experience in trying to integrate in our hospice settings and what we think is the way forward for us to achieve more to work more collaboratively together. So that is what I will cover in this next few minutes. As we are all aware, we know that psychosocial aspects and spiritual aspects are very important in palliative care. And Dame Cicely Saunders' concept of total pain actually highlights the interplay between the body and the mind and how they can influence each other. Right. And in this paper, which talks about the opportunity for psychiatry in palliative care, it talks about the complex mental health issues that palliative care patients face and their family members also face, and where the mental health professionals can contribute. And it starts not only right from the diagnosis of the disease throughout the illness trajectory, into the grief and bereavement period also. There are certain, the psychosocial support is extremely important. I think we are all aware of this aspects. And, you know, in the Leo Tolstoy's book, The Death of Ivan Ilyich, speaks about his mental suffering being the biggest torture. And when Dame Cicely Saunders spoke about mental distress being perhaps the most intractable pain of all, I think we can all relate to it because we see it in our practice as well. And there are a lot of commonalities between the mental health aspects as well as aspects of palliative care. You know, psychiatrists or mental health professionals also look at the biopsychosocial-spiritual model of care. The care that is provided is also patient and family centered. There is a multidisciplinary team. And finally, rather than looking for cure, what we all do is to alleviate the suffering and improve the quality of life. Despite the commonalities, what we see is that psychosocial and spiritual suffering are under-recognized, under-assessed, and under-treated in palliative care. And in places, this is not only in low-resource settings, but we are talking globally. And the integration between the two specialties is highly variable, depending on and sporadic also. Some places have achieved good integration, some places it is not at all available, and often inadequate. So given this scenario, I'll just talk to you about a snapshot of the current practice that we have. We have, as I told you, in Bangalore, a 73-bedded hospice, and on an average, we have filled 70% of the capacity we have patients. We have 6 physicians. We have 6 wards with 12 beds each and 1 pediatric bed. And we have 1 physician for 12 patients. We have 1 psychologist, psychiatric social worker for 1 ward. And we have a nurse-patient ratio of 2 patients, 1 nurse. That's what we have. The counseling team is headed by a psycho-oncologist, and I double up as a director of education, training, and research, as well as the in-house psychiatrist. So this is how the structure of our hospice is. And when we look at the process that we follow on admission, every patient and family, they have undergo what we call as an admission counseling, which is primarily psychoeducation and a rapport building session with the counselor. During this time, the counselor speaks to the family members also separately, because in India, not all patients know about their diagnosis when they come to us, nor do they know the prognosis. So it's important to talk about these aspects with the family members. So there is a separate session they have with the family members. And 24 to between 24 to 48 hours after that, the session happens, and there is a distress are handled by the counselors, the social workers, as well as the volunteers who are available with us. If the moderate to severe distress, we do the PHQ-9 and the GAD-7. We screen them for depression and anxiety. Mild anxiety or depression identified is managed by the psychologist. Moderate depression and anxiety is discussed with the psycho-oncologist who comes in, and if needed, they seek help of the psychiatrist. And in the presence of severe distress, all three, the specialist also, I as a psychiatrist, the referral comes to me. So this is the process that we have, we have for our settings. How much does this work or not work was a learning for me as well. So we did an audit of about 6 months from January to June 2024. We did an audit. Total number of unique admissions to the hospice was 595 patients, of which the ones that were referred to the psychiatrist was 20, which is 3.4%. Okay, of which of the patients referred to me, 43% had a past history of some psychiatric disorders. Much of the referrals came in because patients were agitated or expressed suicidal ideation or desire for hastened death. They were non-compliant with medications, or there was anger in the expressed some amount of anger. And one of the most important aspect that came out was the presence of collusion. 62% of the patients knew that they had cancer. Almost 38% of the patients actually didn't even know that they had cancer, and they had been come to the hospice. And when we talk about the knowledge of the prognosis, that the cancer was incurable, only 24% knew about it. Which shows us a large gap in communication that happens and the presence of collusion. We are doing another study, and interim analysis showed us that 70% was the prevalence of collusion when patients reached to the hospice. The average distress score was 7, indicating moderate to severe distress. Whereas when we looked at PHQ-9 and GAD scores, they indicated mild. And among the 20 who were sent to me, majority had delirium. There was adjustment disorder and major depressive disorder. One was steroid-induced psychosis. The other was a psychosis not otherwise specified. One of them had an intellectual developmental disorder. There was newly diagnosed dementia diagnosed in the hospice setting, and there was a Parkinson's disease, sporadic Parkinson's disease, and all 3 patients were the one who actually had a suicidal ideation. The rest of them had just expressed a desire for death because of the suffering that they were going through. When I looked at the outcomes of the interventions that we did, things were all over the place. I was not able to actually get the outcomes because one was many of them deteriorated suddenly and died before we could actually look at the outcomes. The second, some of them got discharged and were lost to follow up. And so I think these were the difficulties that we faced. So it's like walking a tightrope. Despite having a well-trained mental health team present within the hospice, referrals were very low. One of the reasons is the minimization of the mental health challenges. I think that's a common problem. People don't identify it. The focus is all on the physical symptoms, and this is not identified, and neither by the care providers or by the family. And there is an inherent lack of awareness in how to, recognize mental health aspects, whether it is depression, whether it's delirium, etc. And people don't follow the definite referral pathways. And it's always dependent on the individual physician. Some of them pick up and refer, some of them don't. And of course, palliative care, there's always end-of-life care, hospice care, symptoms are very complex. Much of the attention goes in resolving these symptoms. And there is also the huge stigma. Just like there is a stigma for palliative care, the stigma for psychiatric help is also huge. And among the healthcare professionals as well as among the family members as well and the patients. So these are the tightropes walk that we have to do and navigate these issues. We know that the estimated prevalence is very high in palliative care. Even if I look at the adjustment disorder, 19%, depressive disorder of 50% at when they near end of life, I'm looking at the numbers, 250 numbers, right? Huge numbers. And where are the providers? As a psychiatrist, I'm the only psychiatrist available within the hospice to manage these huge numbers. So that's something that, that's a big challenge that I have to face or we have to face within our system. And this definite pathways and guidelines are not there for specifically for mental health issues, and training is also very poor. These are the challenges that we have to negotiate. Even when they are referred, diagnosing becomes very difficult because it's always cross-sectional that I would be seeing them. Some of the average duration of stay is about 7 to 10 days in the hospice. Either, so either they go back to their hometowns and I'm not able to follow up. So for me to make a diagnosis becomes very difficult, whether it's adjustment disorder, anxiety disorder, it's grief, or is it's a major depressive disorder. So, the inherent difficulties in diagnosing is also there. And of course, understanding that the standard pharmacotherapy or psychotherapy may not be effective because the time that you have is too short. There is evidence for modafinil or psychostimulants, ketamine for use. They are not available in my settings. Sometimes the side effects are so burdensome that I have to pick and choose which drug to use in each patient. And the drug interactions also limit the use of psychotropic medications. And sometimes they are not able to, patients are not able to swallow. Alternate route, finding antidepressants, alternate route for delivery of antidepressants is very difficult. And most of the psychotherapies that we see are developed in the Western world, whether it is dignity therapy, meaning-centered interventions, ACT, calm therapy, applying it in the Indian settings, especially when only 24% of our patients know that they are dying. It becomes a big, big challenge. And the other is the floating population that we have. So many of them come from faraway towns and villages for treatment. Once the symptoms are controlled, they want to go back. And when they go back, whom do I refer them to? Where are the mental health care providers in the villages or in their hometowns? That is where I face the biggest inequalities come in. We know that the palliative care and mental health care needs is very high in India. We talk about a population 6.21 per thousand, and our population is 1.4 billion, right? And less than 1 to 4% have access to palliative care. The mental health gap is 80%. And there is less than one trained palliative care physician per 1 million population. 0.75 psychiatrists per 10,000, where the global average is 3. So I think both in palliative care as well as in psychiatry, we face the same problem, the same issues, and integrating them becomes difficult. We know there is a lot of benefit happens when we integrate and look after the psychosocial issues. There is reduction in distress, there is improvement in quality of life, there is greater provider patient satisfaction, healthcare costs are low. But how do we make this happen? That is the biggest challenge for us. And moving forward, we need to ensure not only, we see in the hospice the end of the patients who are nearing end of life. But this integration has to start earlier on, right from the period of diagnosis. Many of the well-known cancer hospitals do not have palliative care. They do not have a psycho-oncologist or a counselor on the rolls. So I think it has to start from there, that handling the stigma is extremely important, that family members accept this kind of support, as well as the healthcare providers are able to offer it to the patients and the family members. Having clear triggers for referral to psychosocial care, clear chain of responsibility. Who will initiate the triggeral? Whom do you refer to? And having a rapid response system within the hospice or within the hospital for any distress, identification of distress is extremely important. One of the things what we have understood is not wait for the doctors to make the referral. Have an automatic a trigger for referral, which is what we are sort of experimenting now, so that when the distress is high, the triggers come from the psychologist rather than waiting for the physician to make the referral. So these are things that we are putting in place to see if we can improve the referrals. And I think this is the number of training programs that we are running, specifically focused on improving the competency among palliative care physicians to look after mental health issues, as well as among the psychologists to look out to cater to the palliative care population. So the first one is a counseling skills in cancer and palliative care, which is a 6-month blended learning program that we conduct to train psychologists and social workers in providing support for patients with cancer and end of life. Seeing the Unseen is a 2-day workshop that we run for healthcare providers, non-mental health healthcare providers, maybe doctors, nurses, allied healthcare professionals, who can basically provide psychological first aid when they come across a patient in distress. We also run a 2-day workshop in spirituality, focusing primarily on the cultural and context specific aspects. So to empower palliative care providers to provide psychosocial support, spiritual support. And we also have a 2-day death doula training course for volunteers on accompaniment during death and dying. So these are all looking at the training programs that we are continuously evolving and developing, identifying areas, especially in the psychosocial aspects and spiritual aspects, to empower better care of our patients. And I think to conclude, we know that psychosocial and spiritual aspects are extremely important component of end-of-life care. And there is a lot of concordance in goals between the two, palliative care as well as this. And we need to facilitate cross-pollination. We need more psychiatrists, psychologists move into the palliative care in India. Similarly, more palliative care providers need to understand a little bit more about how to provide that psychological first aid. And our biggest challenge has been fiscal sustainability. I think it is like, we are working outside the government. We do not get any support from government sectors. We are an NGO, non-governmental public charitable trust organization, generating funds and ensuring fiscal sustainability for these collaborative models are the biggest challenge. And I as the signboard behind me says, there is always hope. And as Anu also said, we keep chipping at those barriers that we have and hoping to, have a more integrated service and holistic care for our patients. Thank you.
Thank you. Thank you very much indeed, Sima. If you stay online, please, we've got one more final presentation before the panel discussion. So if you could just hang on for a bit longer, we're collecting some questions and comments, but we'd like now to introduce our final speaker for this morning, Murray Cooper. Thank you.
Thank you. On the programme, you'll see it says the Global Network and Beacons. We'll be covering the Beacons this afternoon. Heather, my good colleague, will be introducing our wonderful colleagues who have joined us today. But thank you very much for the opportunity to just take up a little bit of time just to share with you about the network. Heather, I'm going to remind you where it all started. It was a wet, soggy Saturday. We were on a bus to Oxford, coming to see a friend. And it was the year before the Year of the Nurse. And we're thinking, what are we going to do to celebrate the Year of the Nurse? Oh my gosh, 2021. So by the time we got to Oxford to see our friend, we had a plan. And I'm delighted to say what I've heard today so often has been inspiring. These things take time. And Heather's always saying to me, calm down, Marie, we've got time for this. And it's so encouraging to hear colleagues today share about how, 10 years later, what can happen. So thank you. So thank you for that. So just to, what I want to do is just tell you a bit about how it came into being, what we do, and why you should join, and why your colleagues should join. So very warm welcome to our network colleagues joining us virtually. We know you're there, and it's great that you're with us today. So as I said, it started in an Oxford soggy day. And we were very concerned about the nature of nursing. Where is the voice of nursing in the UK and wider? So we thought we need to really reflect on that and see what we can do to get nurses talking about what they value. So obviously get the e-hospice article up. Heather did a great piece about saying, where are all our nurses? And then we look to see where can we send our nurses to give them a platform, say, what is palliative nursing? Where do you go? And for nurses who are a profession, they need a theoretical base to say, this is what we can push against. This is how we can go out and say, this is what nursing is about. So we developed a nursing contemporary model of practice. Last one was done 30 years ago. And that was done with a collective of nurses. So that is, again, a free resource called the Lantern model. And that was really helping nurses to be intelligent about what it was that they offered that is unique to it. Then we thought, right, let's celebrate Year of the Nurse. Let's find those pioneering nurses. And Stella Tata was one of them. We found her in Year of the Nurse. There were about 21 nurses around the globe who we pulled together as a community and really celebrated them and their stories. And then we thought, well, what are we going to do next? How do we hold on to this amazing conduit of intelligence, energy, political savvy, and just, really promoting the role of the nurse, which is such at risk. And so we thought, let's generate this sense of continuity in some way that can work. And some of you, I'm sure, will know about the amazing work of St. Christopher's and the fellowship that has been running for the International Fellowship now for about 5 years. And Heather's key to that. And what was happening was you had all these amazing people traveling together for a year, and then buggering off, not getting a chance to see each other. So we thought, let's pull those nurses and keep them together. And from that, then we realized that if we could keep people together, we would really help this whole thing about professional isolation, which those tall nurses like Anu, you met Anu, we met Anu back in 2015. She was a tall poppy, but she was at risk of getting her head cut off because she was too exposed and her thinking was not something that was going to be accepted. So how do you support these amazing innovators without them burning out or being sabotaged? So we really wanted to support her and mentor her. And as you can see today, the sole palliative care, which she didn't say, is her baby. She has so many babies. She's a super. And also she is a super connector. She knows so many people around the world now. And she has such political intelligence that when she said that service was withdrawn last week, when I spoke to her, you think she'd be crushed, think you're saying, what's the point? But they have a political intelligence to say, it will come again. We cannot give up. So I think we can often get burnt out by so much barriers, but really understanding that that's the world and the context in which you're working. So we decided to set up the Palliative Nursing Network. And what our ambitions is certainly to grow a network of nurses around the world, to really learn together in a very informal adult way, really reciprocity in our learning and really sharing that, to really get nurses to value their contribution. We have a real concern that nurses are often the last port of call and pick up every bit of dross that other professionals want. They run hospitals, but everybody else goes home when there's crisis. I'm not talking about being martyrs, but I'm saying that we really need to understand what is the unique contribution of nurses that we want to really protect and hold on to. Share ideas and expertise and certainly grow the future. And therefore, we set up our champion community. So the model that we've got for our network is threefold. It's to have a program of learning that is accessible and free, and that people can join virtually or on demand and in person where possible. To have a chance to really get nurses to meet and talk and see where they want to take things, where they really want to what's going to work for them, where are their pace and change. And then to really generate this whole thing about leaders through the champion community. And so to date, we launched this 18 months ago, Heather? Can't remember. So we have 830 members so far of 64 countries. And these are nurses who have found us through different ways. These are amazing champions, which was this one. Anu, they come from countries north and south hemisphere. And what you see from these individuals, that they all now have a friendship that is above and beyond us doing anything to support them. They are supporting each other. We have national leaders here who are mentoring others to write policies. We have Pauline from Rwanda, who is leading her own services and really trying to push up in terms of getting nursing education sorted. Sheena from Canada, Christian from Cameroon, Bhutan, you know, a wonderful collection of individuals who are really supporting each other, but also really wanting to support nursing wider. And Pauline would just talk about this network being a place where nursing is safe and supported. And Shelby from Ireland, just saying, the needs are vast, but together we can really find a voice and make things happen. So for all members, what can they expect from our network? We have an annual conference, and that's where we find a lot of our champions and people get a chance to meet each other. We have a spotlight event where we don't focus on the biomedical aspects of care. They can get that somewhere else. This is where they get a chance to think about the voice of nursing, professional identity, deal with things like historical trauma at the end of life, things that nurses and other clinicians are dealing with, but they haven't got a place to really take what's going on here. And we have speakers from all over the world sharing their expertise. We have access to amazing on-demand learning by St. Christopher's, which is free, super resources for there. And we do a lot of work as and when people want it, mentoring and championing, supporting them to do what they want to do in terms of taking things forward. So we have an online presence where people can really come and find out about us. So please do come and see if we can support you in some way. And this is who can join. Any nurse working in children and adult care, working anywhere in any place. So it's completely a free resource. We have it in conjunction with the International Children's Palliative Care Nursing. Julia Downing is our colleague in this. So we have a children's representation. And we just would love you to just get on board, and just hearing today the opportunities for us to connect. It's really fantastic. So thank you very much.
Michael and I will hope to bring together some reflections on this morning to be conveyed on, but immediately this is a chance to ask questions of the speakers who have been presenting just now. And we have one question for Sally.
Yes. Yeah, and thank you very much. So on the chat, lots of appreciation and thanks. There's some lovely comments. But for Sally, Dan Monday, who works in Nepal, so that they have a similar program to the one you described, and just wondered, had you published a report? And the reason for asking it, as well as passing Sally Dan's email address, because I imagine other people in the room will be wondering if there's a report they can access. Thanks, Sally.
Okay. So Dan is saying that they have female community health volunteers. I'm not sure if that's only female.
I read it as such, Sally, but I don't know.
No, I'm not sure.
Yeah.
Do we have a published report? No, we don't actually, not yet. But we did present at the Kenya Palliative Care conference last year, and actually I'm thinking that we should do a report. I think our problem is that only 12% of the patients filled in the before and after, which is actually really quite a low sample. I think that's partly because people just aren't used to doing this. So it's quite difficult to motivate the hospices to get the data. But I think what they found was that it was easier than they thought, and they were quite interested in the results. So I think maybe next time round you get a better sample. But I'm slightly reluctant to publish a report that only has 12% sample, simply because it's so unrepresentative. But maybe I should. I don't know.
People have a response to that whole notion of data collection and how we get it out there.
I have a response. The only rule is for those online, please publish.
Yes.
Even with 12%, because using the APRAPOS to demonstrate outcomes arising from education is innovative, it's new, nobody was doing it probably certainly just before the pandemic. So this is really inspirational, valuable stuff. And if you wanted to be a little bit you were still a bit worried about that response rates, it reflects palliative care. Could you call this a feasibility study? But we need the studies with the small numbers as much as the studies with the big numbers. So this is really, really, really important. Please do. Happy to help if you need anybody to kind of help you drive it.
And that's a very strong message from today here. Data collection is everything.
Yeah.
You've got to get it out there, haven't you? So can I ask if there are questions from the last batch of speakers? Because I know that there are questions to Rob that we held over from before. Who's got any particular questions about? Left as I am, in complete awe of what's going on. It's absolutely wonderful. So I know, so you had a question for, is it?
Not just a suggestion,
Yeah.
because I didn't have the opportunity.
Could you
to write.
introduce yourself, please?
Well, my name is Polaju. I'm a specialist palliative care physician from Nigeria. I've been in the field since 2001, around 24 years ago. I actually pioneered in the country, and I retired 2 years ago. The retired age of 60. So I moved to UK, and I'm now working with Richard Out Children's Hospice in London. So that's my story. But I'm pleased to be here. I've had a lot from Tanzania, Lesotho, everybody. But it's surprising that we don't have anything from Nigeria, a population of 230 million. So I'm inviting you to actually join us, because I'm going back in December to Nigeria. So I was much interested in the domestic health financing, and I've discussed with Bob in challenges which are peculiar to each of those countries. For example, the government, not all countries in Africa have national palliative care policy. So if you don't have a policy, there will be no budget. We had a policy. We work over 2 decades. We had a policy about 2-3 years ago. There is no national guideline. So the implementation of the policy is not there. So there's no funding from the government. So, and if you look at the individual, domestic, let's domesticate it. The economic power is not there. The health insurance is just maybe about 5-10%. And the people don't have the money for their health. So I was just suggesting to Paul that another area which we are not looking at is this issue of, the capacity of the global pharmaceutical industries. We really need to reach out to them. We really need to foster a relationship with them. They need to buy into it, because we are very big. We have money, we have the connection, and we saw this during the COVID-19. We are very proud and have money. That's my suggestion.
Thank you very much. That's that's really important to bring us back to medicine, because we have touched several times on access to medicines, and particularly access to morphine, where we know that there is a crisis across the world about that. And I don't know if Sue, you'd like to say something about what's been happening in Ethiopia about access to medicines?
And also what's not been happening.
And what's not been happening, exactly, that's right. Sue Mumford, who's chair of Hospice Ethiopia UK.
Yes, as George says, we run a charity in this country, with the aim of promoting palliative care in Ethiopia, which we largely do with working with a partner organisation, Hospice Ethiopia, which was set up and is run by Ethiopians. And for about the last 5 years, we've been working through Hospice Ethiopia, trying to get all the morphine into the country. It's a very slow process, where there is now a room set up at one of the large government hospitals to produce the oral morphine. We understand the American Cancer Society has procured the morphine powder in Kenya. But what we're learning is that you need a whole raft of infrastructure in the country around the legislation about producing it, storing it, recording it, getting it to patients. I mean, initially the project will only be, the morphine will only be available for patients at the Blackfriars Hospital. And we're just trying to network with as many people as possible who can help us, help the ministry to get that raft of infrastructure in place so we can finally get morphine not only to palliative care patients, but to all sorts of patients who need, you know, decent pain relief. It's just not there in the country at the moment.
And it was about 10 years ago, briefly.
Yeah, gone backwards.
Yeah.
And what's the experience in Tanzania, Carolyn, around access to morphine?
It's available, and anybody with the right training can apply for the licenses to get it and use it. The country runs out occasionally, but most of the country haven't applied for licenses because they haven't had the training in order to get the license through the pharmacist to be able to dispense it.
And with the training
But they're not, I think they're, it's only Ocean Road still that is buying in the powder and manufacturing it.
So Rob,
there are issues, aren't there, of getting the training and having the morphine to use pretty much at the same time.
Yeah.
We've been talking, as George has, training about using oral morphine and things in Ethiopia for over 10 years. But of course, the people who thought 10 years ago had 10 years of no access to oral morphine. They haven't got the hands-on experience. And trying to get the timing right of training and the delivery of the stuff is quite an issue.
question.
I'm just putting a hand up for Rwanda.
Yes.
I've been working there since 2015. And from the very time we went in, I was amazed to see bottles of morphine on the patient's bedside. And it's continued ever since. So much people need to get involved in touch with Rwanda and say, oh, that's it.
Rob, do you have a comment to make about this anxiety that's being expressed about access to very cheap but effective pain relief?
It's just exactly the type of issue to go for. I would suggest it's very straightforward. Everyone understands it, you know, sort of politically as well, you know, that how can you have people dying in pain, you know, and particularly children dying in pain. I think the Lancet Commission showed that very vividly. So I think it's often difficult to move forward and sort of think of, you know, how do you address all these things simultaneously, the staffing, the education, the infrastructure, the medicine, everything. But when it's so blindingly obvious like this, I think these are the sort of Trojan horses that you use to win battles. And I think access to morphine is an absolute no-brainer. And even this week, actually, at the World Health Summit, there's brand new Lancet Commission, which is very prestigious commission. It's been led by Larry Summers and Dean Jameson, and they got a lot of publicity in Berlin, which is all about how do countries take steps towards universal health coverage. And they are majoring on access to medicines in that report. And, you know, and in particular, a list of medicines to say what are the absolute no-brainers. Almost to say to political leaders, you are not serious about universal coverage unless these things are available for everyone who needs them. And liquid morphine just strikes me as being, you know, the top of that list.
When we were in Tanzania at the very beginning of the Tear Fund project, and morphine was available for us to use, and when we were visiting patients in their communities who were in desperate need of morphine, they would say, I don't want your drugs, I want food. Because poverty was a real issue around that. And there's certainly my team leader that I was working for, she said, we've got to make a decision here. Do we go out and buy food? How do we acquire food, nutrition for people who are at the end of life, knowing that morphine was so cheaply available? So there are these there are all these other issues, the socioeconomic issues. There's a stigma around using morphine. We're about to go and teach in Lesotho, and I think there's still considerable anxieties to better about opiophobia. So you can't go into a training or education program on the assumption that you're teaching to the converted. You have to start way back. But there's one of the messages from yours is is trying to work out where do we start? And I admire your optimism and enthusiasm for getting stuck
Bring the
in.
politicians in from the start.
Yeah.
I mean, honestly, you know, because yes, you can imagine some of these things might face political battles, invested interest in not wanting this to happen, and professional rivalries and all this type of stuff. And if you bring the politicians in from the start, you stand a better chance.
Sorry, you want to go?
I just wanted to share a experience with Nigeria.
Yeah.
But that's a local one. When I graduated in medical school around 1987, we had the morphine, opioid available. But along the line, it was being abused. They were not actually taking stock about it. So the INCB banned the country. So for about 15 years, there was no opioid in the country. Because you know the INCB governs. So when I started, I was an anesthetist for 20 years before moving into this field. So when I started with the palliative medicine, we have to liaise with the pain society to move very hard on the ministry that we should have this medication. And of course, the palliative care who were at the forefront. So the opioid came in, the government bought it, a lot of negotiation with the Ministry of Health. By the time the opioid came into the country of more than 200 million people, only 3 institutions were using it. Those are the pain professionals and palliative care professionals who have the skill and knowledge to use it. 3 institutions with 200 million people. So most of the medications got expired, wasted, because there was no training. So, and with that, the ministry was actually frowning about it, that we brought a lot of things over 15 years and got wasted. We are no more interested. And you know what made it more dramatic is that for 15 years gap, the doctors and nurses that were trained within that 15 years and became doctors and nurses, they never seen the opioid before. They don't even know how to prescribe it. They don't even know how to dispense it. So it took us another 3-4 years before we now come back to be able to adjust and start massive training. So what I'm trying to say next is that the availability, the advocacy, everything will go hand in hand with education and training, because you cannot give what you don't have. It will waste. You get wasted. And it's quite improving gradually now. But the opiophobia is not only for the healthcare professionals. Even our so-called patients, they also have opiophobia. Because the nurses who don't have the skill will whisper unto them, please don't take it. It's meant for these people that are dying.
Thank you for that. I was a timely reminder of that, of all of those challenges. There's a question behind you. Sorry.
Yes, not directly related, but
could you introduce yourself?
yes, sorry. Susie Lapwood, I'm retired clinically now, but was part of the medical team at Heaven House and Douglas House Children's Hospice here in Oxford. I was just very struck, Robert, about your presentation right at the start. I thought it was really helpful. But just saying that there is no indicator of global palliative care coverage. And I just thought, if we don't have a good indicator, what's missing? What do we need? What's there? What could we adapt? Is there a proxy? We have a wealth of varied expertise from various countries here. And I just wondered if it was something maybe for discussion, because if we want to have good leverage politically, economically, to get universal healthcare coverage, and palliative care is on that list, we need the data, don't we?
Yeah, absolutely.
Yes, I mean, we were chatting about this before, and I think this is a problem, you know, because governments are being held to account on universal health coverage, and there are a number of indicators that make up a service coverage basket, really, and countries are tracking how they're doing. Now, in that basket at the moment, there are things like immunization coverage and some supply side things, which actually aren't a very good indicator, like number of doctors per 100,000 people. They're not necessarily seeing patients. You're much better looking at where there is an express need for services, are people getting those met? And were it possible to come up with palliative care one, then that could go in, and then countries will be suddenly thinking, gosh, if we want to increase our aggregate score, we can't neglect the palliative care one. We should promote that one as well. We actually had a discussion about this at Chatham House. I actually took that slide from that round table. They didn't come up with one there, but I think it still is up there as that. I don't know, maybe even something like coverage of morphine. Might actually, sometimes these things, they're not perfect, but if you can at least get something like that in there, that you've got a foot in the door.
Thank you very much indeed. Are there any other questions? Because you have been a fantastic audience in keeping and speakers in keeping to time, which is great because that gives us an hour for lunch. Is that right? And that's a wonderful opportunity for people to chat, share experiences, get to know each other. I know that Gillian has got a comment to make about the toolkits. Is that right, Gillian?
Well, yeah, I will make a comment about the toolkit, but I wanted to say something else as well.
Oh, sorry.
Some of you may have picked up a toolkit, which is the earliest version. We revised the toolkit, so could you just check the second version is out on the table there? We would really want you to have that second version.
That's the 2016 one.
2016 version.
Yeah.
Yeah.
Thank you. But you had a comment, sorry.
Yeah, I just wanted to, so I'm Vivian Chance, I'm one of the trustees, my background is in social work. And I just was reflecting on all the presentations this morning, which were fascinating. But for me, one of the key things is about the social context in all of those. And in one sense, no matter how many people you have trained, how much morphine you have, other things, is the things out with that really make the difference, and that takes us back to politics. And so I just wanted to pick up on this notion of universal health coverage, because I think it was quite late in your presentation, Rob, that I heard those wonderful words about some countries who were doing a radical overhaul of health and social care. And those two last words will music to my ears. So I just wanted to say something more about that, because I think it's such an important.
Oh, absolutely. And I think this has been one of the great problems we've had in the UK, that have often been treated very separately. And that you look at, issues like, say, long-term care of the elderly, which has been sort of kicked down the road for so many years by previous governments, and is largely funded by local governments, not central governments. And I think we're seeing so much, around this interaction of healthcare, social care, the social determinants of health, the wonderful work of Michael Marmot and everything. So it is so important that these things are tackled simultaneously. And my mother was a medical social worker, and then went to community social work as well. So this has very much been to me. Couldn't agree more. And I think this is encouraging that that in the UK context now, these things are increasingly being brought together. But I mean, goodness gracious, that should have happened 70, 80 years ago, shouldn't it? And we're just starting in a number of other countries like this. But I think there are political leaders thinking about this. It was interesting in the height of the pandemic, Imran Khan in Pakistan was talking about building a welfare state, sort of based on things like access to food and healthcare, and so bringing together the social aspects together there as well. So I think working with political leaders in countries to say, you don't have to wait 80 years like we did when we started our welfare state. Start with these things integrated.
Thanks for that. Yeah. It's at this point that we say farewell to our delegates on Zoom. The conference ending on Zoom now. So if I could ask you to give a round of applause to all our visitors. Yeah. And a round of applause to our speakers from this morning.